Hey, welcome back to Doc Talk Live. Good afternoon, Sarah. This is Dr. Sara Gould. Sarah is a sports medicine specialist, correct? And you specialize in concussion.
Pediatric concussion is one of the things that I do at Children's in Alabama.
Okay.
We have a clinic over there.
Well, I appreciate you coming on. Blake, who you can't see, if you flip it around, they could see you, Blake. You want to do that real quick?
Sure. Hi.
That's Blake. All right, so we're back. Blake has been encouraging me. He says, you've got to talk about concussion. Football season has started, and it is a pertinent topic for the time. And I guess where I want to start with this is, how did concussion become so prevalent to the point that when I was in medical school, we didn't have concussion clinics. You know, we didn't have clinics that are just devoted towards kids having mild injuries to their head, mild head injuries. So give us a little historical perspective. How did we get here?
Well, I think that, there's the old axiom which says, I've never seen it, but it may have seen me. So I'm not sure that it wasn't that there wasn't concussion out there before, but that we weren't appropriately recognizing and treating it. I don't think that people understood the pattern of injury, the consequences. A lot of people talk about the movie Concussion, which actually doesn't necessarily deal with concussions, but the consequence, which is chronic traumatic encephalopathy. So we didn't know what concussion was. We didn't understand the prolonged impact until we started having the laboratory, the physiologic data, started seeing people at the end spectrum of life who had cumulative injuries. And so I think that made people realize, hey, there's something else going on here. We need to look at this. And now I think that people are more concerned about it, appropriately so. One of the things that's important to remember about concussion is that depending on which study you look at, around 85% of the population will get better within a couple weeks. And so because of that, it may be something that is self-limited for a large percentage of the population. So they have a concussion, they don't feel well, but maybe gets better, goes away without any type of intervention. And then of course there's the population that we see in our clinic, the ones who don't get better in that time frame.
Tell us about your clinic population. What type of injuries do you primarily see, and when do they typically present to you at your clinic, at your stage?
We see kind of all stages. We get concussions referred to us straight from the emergency department. So, if they get hurt on Friday, they might come and see me on Monday. So we see, very acute injuries. That happens more so during football season. I would say there is definitely a seasonal variation in what we see. When we have a lot more kids playing contact sports, we see more concussion. So autumn tends to be a pretty busy time for us, and we see a lot of acute injuries then. Throughout the rest of the year, we see a mix of children referred to us from all over the state, and even kind of the tri-state area, who have not gotten better from their concussion, and it could be anywhere from 3, 6, 9, even a year after their initial injury, and are still struggling with symptoms.
I definitely want to hit that population, so let's make sure we hit that sort of chronic concussion. But I think you see more than just kids playing football. I think you see kids from cheerleading and soccer and basketball, like sports that I wouldn't necessarily think as concussive.
We see that's, I would say right now, because it's fall, that's what we're seeing a lot of. But I've seen golf-related injuries. The number one cause of concussion in this country, and this is what I always tell parents, is not football, it's motor vehicle accidents. We see a lot of kids coming to us who have been in motor vehicle accidents. So virtually anything that causes a head trauma or even a quick jerking of the head can cause a concussion.
Try to describe that to our viewers about what the brain is doing inside this sort of bag of water inside our brain or
so in my office I have a snow globe, and I use that to try to explain to people what's going on. The brain is kind of the consistency of Jell-O, and if you imagine it in a snow globe, and then you shake that snow globe, it's going to kind of hit the walls of the glass. And that is what's happening with a concussion. The medical term for it is a coup contra coup, where the brain hits one side of the skull and then hits the other.
Can you actually see bruising of the brain if patients have died? I mean, can you see things like that at autopsy?
So you can definitely see structural injuries. You can see head bleeds. You can see skull fractures. Some of those things happen. But we used to say that concussion was a functional, not a structural injury, meaning that you wouldn't necessarily see it on a CT or MRI. Now we are developing more advanced imaging capabilities. So we have fMRI, we have other, some people are looking at PET scanning. There's a lot of different things. Unfortunately, it's all in the research stages right now. So there is no imaging study right now that can diagnose a concussion. But that doesn't mean that if you hit your head, you shouldn't get a CT scan. A CT scan could show a brain bleed, a skull fracture. So I always advise people, there's really lots of literature out there that says when and when not to get a CT scan. So I would definitely go by that.
Where are we with baseline screening? So I would imagine that like all the college football teams have sort of a baseline cognitive screen. Where are we with that in the high school area? And do you have any role in baseline screening? And tell us about that.
It's really interesting that you bring that up, because we just started a joint journal club with NYU and Dr. Hainline, who's the chief medical officer.
Brian Hainline?
Mm-hmm.
He's from Michigan.
Oh,
Actually, he's older than me. He's a neurologist.
Mm-hmm.
But Brian was a great tennis player. He played tennis for Michigan, and I think he's actually the head tennis person for the U.S. Open. But yeah, he was a great tennis player. So anyway, go ahead.
So we just started a joint journal club with NYU, and he led the most recent journal club, Concussion Journal Club.
Mm-hmm.
So it's a coordination between UAB and NYU. And he led it, and it was actually on baseline testing. There's a lot of controversies. Everybody thinks that we should be doing it. Nobody's really agreed on what the right test is, and none of the tests are 100% accurate. They all have flaws. That's kind of the short gist of it. You get way more in depth in that.
So you don't do any baseline testing?
So the NCAA has rules and regulations, and they just came out with, or within the last year, came out with a paper on baseline testing. So I would encourage anybody who's interested to read that. That was one of the things that we discussed at our journal club. In terms of my role at Children's, I am not personally doing any baseline screening, and that's because I'm not doing a lot of team coverage. I do cover the women's basketball team, and we do baseline screening for them as part of that. However, in my role in the concussion clinic, it's not a primary team coverage role. Really, it's the team physician's responsibility to determine what type and how they want to do their baselines.
Okay. This is all kind of like a cognitive test that they kind of. Brad was talking about this the other day.
Who was?
Brad Smelly. We talked about this in the OR the other day about how they were starting to do some of these baseline tests.
So just to back up for our viewers, that the biggest problem with a concussion is that it causes cognitive issues, right? Like thinking, headache, not just pain, like visual, not just visual, but the ability to think. Memory would be an example.
So I usually talk about concussion as having kind of different baskets of symptoms that we usually see, and I always will ask about when I have a patient coming in. So you can see disturbances in sleep, you can see emotional disturbances, you can see difficulty with concentration, memory, focus. That's kind of all lumped into one. Difficulty with the vestibular system, which is sort of balance, eye tracking. A lot of the eye stuff falls under that. And then somatic. So a lot of times we'll see neck pain or neck injury associated with the concussion, back injuries, that kind of thing. Other issues, musculoskeletal issues.
But the cognitive issues could be the most pressing, or I guess tell us about what are typical cognitive issues that patients would have.
So I think that it really varies. Certain people will have terrible vestibular issues, and I don't think necessarily that's always appreciated. We have kids who come in who can't read because their eyes can't track, and it's very profound when you see the eyes kind of roving and not being able to track, because you need to be able to track back and forth in order to read, follow in the classroom, and it's very debilitating if they cannot perform that. So I think it really depends on the individual, but you can see in any one of those symptom kind of categories profound difficulties following a concussion. Cognitive disturbance is certainly one of them. There's lots of different treatments, medications. We'll do speech therapy, neuropsych testing to kind of look and see where exactly the difficulties are, and then try to devise treatments for them.
What kind of medications do you use?
So there was a paper that came out showing that there's a couple different types of medications. Amantadine, which is not a stimulant, and then some stimulant medications
like
can also
Ritalin?
be helpful.
Would that be an example? Or?
That's one of the stimulants that you might use.
All right, take us on the field, okay? Because.
But that's just want to back that up, just for everyone out there. That is not first line. That is not, I hit my head on Friday and on Monday I'm confused.
I just didn't even realize there were any medicines at all.
We're talking that 6 months into it, I'm still feeling confused. And that's one thing that I think is important as we talk about different treatments. There are so many different things that we can do, but the natural history of concussion is that it will evolve and get better. And so you don't want to ever start somebody on a treatment that has side effects or risks until you're very clear that they've kind of plateaued in their symptom kind of progression. And once they plateau, then you can look at doing medications, but you can actually really hurt people if you start them on medications too soon from side effects, and also they can't return to play until they're off their medications. Otherwise, you're kind of masking the symptoms. So for a lot of different reasons, it's not a good idea, if you get hurt on Monday to come in, Tuesday and think that you're going to get put on medications or therapies.
On that same topic, how hard is that for you to determine, are some of these side effects or not being able to concentrate, was this pre-existing before the concussion? Just like
that's
ADD,
why they have
ADHD,
baseline testing, I think.
But for an adolescent, though, that maybe just playing rec sports, certainly not every 10, 12-year-old's going to go get a baseline. So that's got to be very difficult trying to differentiate what was pre-existing and psychologically now, what are they like?
And that is definitely something that we do run into. And one of the things that kind of helps, this is something that we deal with on, for these more complicated cases that aren't getting better. We kind of we do symptom assessments, we look at cognitive, there's different things that we use in the office to kind of track how the patient is progressing. And so when we see them plateauing at a certain stage, then we know, we have to assume this was from the concussion because, it's kind of here and now it's here and then it's kind of stayed here. And then our neuropsychologist colleagues are very helpful if we're not sure. And they do very in-depth testing. They'll look at, prior history, prior grades, test results, that kind of thing. Okay. And if somebody does carry an underlying diagnosis of ADD or ADHD or another type of learning disorder, that does predispose them for having a more difficult recovery.
Take us on the field now. I want to get to second impact syndrome, but take us on the field. Athlete suffers a concussion, and what's the assessment there immediately on the field, and how do you determine whether that athlete can return to play, and how has that evolved?
So, the sideline concussion assessment tool, the SCAT, has gone through various versions. It's on a SCAT 5 now. It hasn't changed too much from the last version. And that it's, you can look it up. The CDC has great resources on this, so I really recommend people going to the Heads Up CDC. Maybe you can post a link to that. It has all of these different tools, the sideline assessment tools that you can use, symptom inventory checklist. But the bottom line is, if there's a question, and they say, when in doubt, sit them out. If you're not sure, poll the person, because you can go on to have worsening injuries, the person, and it's not just necessarily even another concussion, but if a person's confused, they're not running the plays right, they're going to get, they could get hit, their balance may be off, they could fall and end up with an extremity injury, a torn ACL, something like that. So it's not just for the head, although that's very important, but you really have to think globally about it.
Tell our viewers what second impact syndrome is.
Second impact syndrome is when you have a hit while you are still recovering from the initial head injury. And it's sudden cerebral edema, which causes herniation, meaning the brain swells and can...
So the brain is more vulnerable to a much worse brain injury if it's already in the concussive stage.
So if you are... Second impact syndrome is something that is almost more theoretical. We don't really see, it's not something that I've personally ever seen or heard of any of my colleagues seeing, but that's not to say that what we do know is that if you are recovering from a concussion and you get another head injury, you are more likely to suffer a worse and more prolonged outcome. So, whereas if this is just hypothetical. If you had somebody who was recovering and they went back too early and their recovery period may have been a month, they get another head injury and maybe it'll take them 6 months. That's just an example, but the idea is that if your brain hasn't fully recovered, it's more vulnerable to repeat injury.
Got it. So you're on the football field and do you take them out for a quarter, the whole game? How do you decide whether to...
So there's no same-day return to play a lot of this is, this depends on whether you're talking about professional, collegiate,
so it
intramural.
It varies from level to level.
And these are policies, and from league to league. All the leagues have a different policy. We actually wrote a paper on some of the publicly available data about what the different league policies are. And so the different leagues have different policies. They have different ways of managing this, return to play. But the bottom line from what I do is I feel like that's the team physician, because a lot of this does come into, how well you know the person, how well is this person acting like themselves. Having that background is very, very helpful in terms of making an immediate return to play decision. And that's not something that we do a lot in my clinic. In fact, I do get collegiate athletes sent to me who, had a concussion and they kind of maxed out what they could do at their institution, and then they come to see us for, a second look, second opinion. And I always tell them,
have you ever been the doctor at a boxing match? Because the way you win is, I guess, to cause a concussion to the opponent, right?
Well, a concussion doesn't necessarily have to have a loss of consciousness, but yeah, if you're going to knock somebody out, I don't cover professional boxing.
All right, I want to jump into treatment, and my understanding of treatment is brain rest.
So that is something that we used to think, and now we've discovered, there was a study that came out a couple years ago that said that if you kind of shut people down, they actually do worse.
Interesting.
So the idea is you want to allow people rest and recovery in the immediate kind of post-concussive symptom period. So, 24, 72 hours following the initial injury, rest is fine. But after that, and especially once you get, 3, 4, 5 weeks out, we really want to start encouraging gentle physical activity, getting involved, keeping a schedule, getting back to school.
So how long would somebody stay out of school for?
Well, that's really an individual question, but I feel, and I think my colleagues feel, that the sooner you can get someone back to school, the better they do psychologically and recovery-wise. That doesn't mean that when they go back, they're going to just jump straight into everything. They may go back and just listen and try to kind of absorb some of the information. We call that passive learning. And then kind of progress through a return to learn protocol. Or they may go back and they may be able to read and write, but maybe they need some extra time for tests. Every individual is different.
So it's very individual, but you're trying to get them back sooner rather than later. So it's sort of flipped around. When I was doing brain injury, let's say, way back in the 90s, so brain rest was really key. And so now now you've got to exercise your brain at least to a certain extent. What about screen time? How does that play in?
So screen time, I think that's one that's still fairly similar. Definitely not before bedtime, because obviously that can inhibit the person's ability to fall asleep. The brain's already confused, so it may not know the appropriate sleep-wake cycle that it's supposed to be on, so we don't want to do anything to further disrupt that. Also, we talked briefly about the vestibular symptoms, so the eye tracking movements can make people feel really sick to try to read, track, seeing things kind of move around on a screen and have to track that with their eyes. So we usually do limit screen time. I don't find that it's helpful to completely cut people off from screens, because it is such an important part of the way that people interact socially, that the psychologic symptoms become much more severe if we completely cut people off. And so I find it more beneficial to restrict it, cut it down to maybe 30 minutes of 5-minute intervals throughout the day, so that we're cutting it down to the bare minimum possible, trying to stay at a sub-symptom threshold, meaning don't do it until it gives you a headache. Stop before you get a headache or feel sick or dizzy. But I don't find that it's helpful, because it's a balance. You're already having somebody who was maybe a member of a team who's been cut off from that social interaction. You have somebody who may have been going to school and may not feel well enough to go to school. So you're cutting them off that way, and then it becomes very, very isolating, and we see a severe exacerbation of the psychologic symptoms. And so it's important to kind of balance all of the symptoms.
So tell our listeners how people find your clinic. What's it called? Is it called the Concussion?
The Children's Concussion Clinic.
And is it here at Highlands, or
it is at Children's?
It's at Children's.
Mm-hmm.
Okay. And is there a phone number to that clinic? A main number?
If they have a concussion, they need to be treated, they can just call our general scheduling number. We can post a link to that, and they ask to be seen in the Children's Concussion Clinic.
Perfect. Have I missed anything that we should have covered? Is there anything on concussion that, I mean, I know there's a lot more to it, but is there something that we should discuss that we haven't?
There's so much on concussion. There's so much controversy. That's one of the things that I think is so neat about it, is that virtually every month that goes by, there's a new paper that comes out. From year to year, we may do like a 180, where before we were saying brain rest, now we're saying, actually, you really need to be doing some physical activity. So the way that we approach the treatment evolves so rapidly that it's a really cool thing to be a part of.
So if we do this show next week, are we gonna change everything?
You never know what's coming down the pipes.
There's a saying, it says, if you quote me, date me. So anyway, Sarah, I really appreciate you taking time out of your day to do this. Blake, do you have?
Just a quick question. I have a lot of questions, but it's hard to get into everything. But are we at the point? I think that with all the controversy with CTE and all that, are we still trying to determine, does concussions cause the CTE, or have we determined that yes, it does, or is that kind of the link that we're still trying to connect the two?
Well, I guess it depends on who you ask. If you ask the NFL, they would probably say no. I mean, I'm joking, of course.
Sure, yeah.
But I am being somewhat serious in that I think that it's much less controversial than it was in the past, the link between CTE and concussion. But every day there's more and more data that we are adding to the database in Boston. And every day we're getting closer and closer to developing imaging techniques that can try to diagnose and actually see a concussion. And as we develop these new tools, I think we will get to the point where we can definitively say what many people suspect, which is the two are tightly linked.
Okay. Sarah, I appreciate your time.
Thank you.
Thanks again for doing this. I guess we'll just stop it there.
Stop. Yeah.
All right, great.
We have, if you you just Google like children's concussion, there's a website and information because a lot of them don't want to go back to school, and they may be on passive learning where
I think we're still live. Are we still live? That'd be cool if we are. Are we still live? I think we are. Hey, that's Blake. Say hey, Blake. So I think we have to hit finish.
I hit finished. Does it